So let's set the scene. You and your partner have been dispatched along with another unit for a female party in active labor. So you arrive to find a 22-year-old female. She is in active labor. She is G1P0, has not been great about her prenatal care, and thinks she is pretty sure she's around 35 weeks pregnant or so. So the baby's premature. Anywhere between 37 and 42 weeks is considered term. 35 would be considered a late preterm pregnancy. Um, so the other crew basically gets the patient down into the ambulance. The patient's on your stretcher, and you notice the infant's crowning. So delivery is definitely imminent. But you have a plan. So the first crew will treat the mom, and you and your partner are solely on baby duty. So take a minute and think about what equipment you would need for this. If you already work on an ambulance, do you know where to find that equipment within your company's truck? So here's kind of a list of equipment suggested by the American Academy of Pediatrics Neonatal Resuscitation Program, or NRP. This is their delivery room checklist, so it's not identical to what you'd have in the ambulance, but it gives you a good start. And then I suggest you either look this up or kind of pause the video here and save this somehow, because this is all the stuff you're going to need. But fortunately for you, your company has a kit, it's prepped, prepared, so you kind of move on from here. So, kind of the first question here. Unfortunately for you, you look over at the birth and you see that the baby has a nuchal cord. So, what is a nuchal cord? All right, so a nuchal cord is when the cord is wrapped around the baby's neck. Usually, it's caused by actively kind of activity or turning of the fetus within the womb. Um, a single wrap is relatively common. It happens at around 20% of births. It's relatively easy to manage. You just kind of slide it over the baby's head as they're being delivered. Um, More than one wrap, so it can be wrapped around twice, three times, etc., is pretty rare. It's around 1% of all births, and it can actually be a challenge. And that's unfortunately what happened here. So the team tries to unwrap the cord from the baby's neck, and after a bit of struggle, they finally do, and the baby is delivered. But the team kind of holds him, does their initial thing before handing him up to mom or back to you, and you notice he isn't crying. They're floppy, blue, and have only gasping, agonal breaths. The other crew quickly cuts the cord, places the baby on the stretcher, and here's what he looks like. He's definitely going to need some resuscitation here. So let's take a look at the neonatal resuscitation algorithm. So he's floppy and gasping, so you have some work to do. To be fair, though, let's give him a second, right? Babies take 30 to 60 seconds or so to kind of perk up. It can take up to 30 seconds for that first kind of big breath. The floppy part isn't a great sign. Babies should have good tone from birth. They should be kind of flexed and kind of curled in a little bit. So you warm, dry, stimulate the baby for about 30 seconds and still nothing. So you try to suction the mouth, then the nose, something you know isn't routinely recommended anymore, but you figured you'd kind of give it a shot since nothing else seems to be working. You need to do some resus here, so you position the airway and with some towels kind of under the shoulders, you already had those prepared, and you start to ventilate him, knowing that you're kind of going down that pathway anyway. So to put that in perspective, you have 1 minute to start doing that. So, how much oxygen should you use to ventilate this baby? So the answer here is none. Per NRP, you use 21% FiO2 or room air for the initial step in resuscitation. Oxygen actually isn't great for these little kiddos. Room air is a room air has a significant short-term reduction in short-term mortality. There we go. Compared to 100% oxygen in these kids. These kids' physiology is different than yours, so keep that in mind. Oxygen's not awesome for them. We'll eventually get down the pathway where we may have to put them on 100% oxygen, but the initial resuscitation here is actually done with room air. So it's the bag with room air or medical air. So, as you are dealing with that part, your partner is going to calculate an APGAR score. You need to do this at least twice, once in the first minute and then once at the 5 minute mark. So APGAR is a standardized assessment of a newborn. So it stands for appearance. So you're looking for skin color, pulse, which is you're going to assess generally the brachial pulse, grimace, which is basically kind of a reflex irritability, activity, which is basically their tone, and then respirations. So a perfect score is 10. The worst is a dead baby at 0. Ideally, you want at least an 8 at 1 minute. Lots of babies don't have 10 at 1 minute. That's perfectly okay. They'll perk up and be 10 by 5 minute mark. But if the score is 7 or less, you actually have to do this every 5 minutes for the first 20 minutes of life. So you'll do it a bunch, but you have to do at least the first two. So one at 1 minute, one at 5 minutes. And our baby here has purple arms and legs, a heart rate of 80. So slow, gasping breaths. They're listless and they have basically no response to stimulation. So with that in mind, what is their APGAR score? So this kid's APGAR score is 3, not very good. 1 point for peripheral cyanosis, 1 point for heart rate less than 100, and then 1 point for slow, irregular breathing, and then it's a 0 for everything else. So going back to our algorithm here, we need to bag this kid, which we're already doing. You want to ventilate at a rate of around 40 to 60 breaths per minute, way faster than a normal kiddo. So keep in mind, babies breathe a lot faster than standard pediatrics or you. So you need to breath every second or so. Ideally, you would use what's called a flow inflating bag, right? Our standard BVMs are self-inflating bags. This is a flow inflating bag. Usually it's called a Mapleson. I think that's a brand name or something. But it's basically an anesthesia bag, and it keeps a constant flow of oxygen and can actually be used as CPAP too. So the initial settings generally are a 10 liters per minute flow, blended oxygen at room air, so 21%. A PEEP of 5, and then you would usually will set your inspiratory pressure release at 25, which you can set with this type of BVM. If you don't have one, a standard infant BVM will be okay. Just throw a PEEP valve on it, and then just be really careful not to overinflate their very, very delicate lungs. Basically, in, out, in, out, in, out. You have a good rhythm going, and you're careful to squeeze until you see chest rise. And again, that's one every second or so. So you don't really see chest rise well, unfortunately, with your bagging. And as you're ventilating, another crew member places the pulse ox on the preductal wrist. That would be the right wrist. Remember, these neonates are new to the art of breathing, and until about a minute ago, their lungs were completely closed off to blood flow. So they have a patent ductus arteriosus that keeps blood mixing. So you want a preductal sat, which is going to be that right wrist. And the right wrist is a great spot for this. Their fingers sometimes are way too cyanotic, or they don't have enough perfusion to get to those yet. But most of the little guy SpO2 like wrap things will fit right on the wrist, and that's usually where I go. So your SAT is 65 and the heart rate is 80. So are you worried about this SpO2? The SAT is 65. Are you worried about this SpO2? So I'm not. I'm actually not worried about the SpO2. I'm worried about the heart rate though. The SpO2 is actually not bad. So it takes up to 10 minutes for even like a perfectly healthy normal baby to reach a normal SpO2. The first minute of life, you actually expect the SpO2 to be around 60, 65%. That's perfectly normal. Um, you know, there's 60 seconds in a minute, 60% SpO2. That's kind of how I remember that. And then it should go up by roughly 5% or so every minute after. So like 2 minutes is 65, 3 minutes is 70, 4 minutes is 75, etc., etc. That's all normal. You don't measure oxygenation in these kids based on SpO2. You actually measure it based on their heart rate. So he gets placed on the cardiac monitor. You're going to want that heart rate. And you know that's where the money is, right? Like the heart rate is going to be the thing that we're looking for. So come on, heart rate, be greater than 100. Nope, 70. Not good. So heart rate's less than 100, and this is an indication for positive pressure ventilation. But it's okay. We knew we were heading down this road, and we're bagging them anyway. But your ventilation isn't working so great, right? Look at that heart rate. It's obviously not helping. So let's fix it, right? It's kind of the next step here. So you remember that there's a mnemonic for this, and that's called Mr. SOPA. So let's work our way through that kind of using our scenario here. So the M in Mr. SOPA stands for mask adjustment. So basically you ensure that you have a good mask seal. You're not pushing the mask down, but rather kind of pulling the face up. You have, one part on the bridge of the nose, the other part resting on the chin. You have a good grip, all of that, and that's all good. So next, the R is for reposition the head. So you ensure the head is in the right position. You have an ear to sternal notch positioning, just like in adults, but you have a towel under their shoulders. Keep in mind, kids have a big occiput. And you're going to kind of bring everything in line to make sure you aren't hyperflexing or hyperextending the neck. Hyperflexing being this, hyperextending being this. These guys' tracheas are actually really soft and pliable, and basically hyper anything is going to obstruct their airways. You can actually manually obstruct their airway by not positioning them properly. But it's all good. You made sure that's right, so your positioning is great. So now you're going to go ahead and hit S, which is suction. So you suctioned once already when they were first born, but let's do it again. This time we're going to use a soft suction catheter to really kind of get down in there. There you get a little bit of fluid out, but nothing super crazy. So you don't think that's the issue at this point. So now the O, we're going to open the mouth. And this is generally what they're talking about, is doing a jaw thrust to see if that helps. And nothing. Still not helping. You can also try an oral airway here. So let's just say you throw in an OPA, still nothing, not helping. So now we've hit P, which is going to be pressure increase. So now we're going to squeeze a bit harder. This one's tough without a Mapleson bag, where you can set a pop off to a specific pip. Normally you would increase it to 30, but let's increase it to 40, still watching chest rise. How much pressure do you need to actually move the chest? But you're going to be careful. You're going to watch that like a hawk, because you just want to go until you get chest rise. However, for us, we've increased the pressure. Still not great. Heart rate is still 70. So now we're moving on to A, which is just alternative airway. So now we need to consider an advanced airway. So do you want to use an LMA or an ET tube? When is the last time you took a whack at an infant airway head in the training room at your station? A few years ago? Was it a couple months ago? Was it a couple days ago? Let's just go with the LMA, and that's fine. LMAs are fine here. And just like an adult, or in adults, like we favor ET tubes because we want to kind of protect the airway from aspiration. If you think about it, the baby hasn't even had their first meal yet, so no super worries for aspiration here. You throw the LMA in and, stop bagging for a second, throw that in, start bagging, connect it, put pressure on the LMA, you seat it just like you would in an adult, basically. A size 1 LMA will fit most neonates unless they're like super premature. And it seems to seat okay. You attach the BVM to it and you get some chest rise with your ventilations. Okay, cool. So now let's kind of look at the big picture. The heart rate 65. That's not good, and the SAT is still only 60. So now we need to think about intubation or bumping up that FiO2 to 100%. So we bump that right up. You turn on the O2 and you start ventilating with 100% FiO2 now, and you consider intubation, but your partner kind of gets your attention and points to the monitor again while you're making that decision. And you look at the monitor, praying for a higher heart rate, but no, 65, 60, 55, 50. What needs to be your next immediate step here? All right, so as a last-ditch effort, you turn on that oxygen, you start ventilating with 100% FiO2, you look at the monitor, still doing terrible, you need to start CPR. So neonates are 100% dependent on heart rate for cardiac output. They have no inotropy. I mean, they have some inotropy, sure, just because their heart is physically beating, but they don't compensate by inotropy or contractility, right? They are almost entirely dependent on their heart rate. So now they only this baby doesn't have enough heart rate to perfuse the body. That 60 isn't going to give them enough cardiac output, which is why we need to start CPR if the heart rate gets less than 60 in a neonate, even if they still have a pulse. So your heart rate is less than 60, you do some CPR. And there's two ways to do compressions here on neonates. There's kind of the hand wrap method using 2 thumbs, and then there's the 2-finger method. But you know that you want the hand wrap method with the thumbs. It's actually way better. It gives way more effective CPR. So you do that style. And CPR neonates is weird. It's a 3-to-1 ratio. So you have compression, 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 ventilation. So it's 1, 2, 3, breathe. 1, 2, 3, breathe. 1, 2, 3, breathe, right? You always pause for that breath, even if they're intubated, which is a change from PALS or ACLS. So even if the patient has a perfectly placed ET tube, you don't continue to breathe like you would in an adult at that point. It's still 1, 2, 3, breathe. 1, 2, 3, breathe. It's okay to pause CPR in these kids to do that breath. You want to get that breath in. You want to make it effective. You want more breaths than you would in an adult. And this is the kind of best of both worlds way to do that. These kids almost always have a respiratory problem. All right, so we decide to give intubation a go. So what size ET tube and blade should you use? Keep in mind they are 35 weaker. So for the ET size is determined by the gestational age. So you take that gestational age and you divide it by 10, and that should give you your ET tube size. This kiddo is a 35-week gestation, so 35 divided by 10 is 3.5. So we would use a 3.5 uncuffed ET tube. There has been kind of a big push recently to go with cuff tubes in kids, and that's great. I love it. But in NRP, it still recommends uncuffed tubes. There's a few reasons, but we'll save that for another video. If you don't know the gestational age, here's a quick tip. In general, a term kid will be a 3.5, a preemie will be a 3, and if they're like a really preemie, it'll be a 2.5. Not a ton of services carry a 2.5, so a 3.0 will be fine most of the time. As for blade size, most babies can be intubated with a Miller 1. For tiny babies, you can use a 0 or a 00. I actually like using a 1 for them too, personally. Use what you think will fit. I like the additional length and room it gives me by using a 1, even if the baby is smaller. But those are like the traditional teaching ones. So this baby is 35 weeks, which is kind of a late preterm. Late preterm is defined by 34 to 36-ish weeks. So he's almost cooked, but the textbook answer here is a Miller 0. But again, I actually still like a Miller 1. All right, so you get the tube. Awesome. You used a 3.0 tube and a Miller 0. You secured it at 10 centimeters since you know that it should be roughly 3 times the tube size. And then you confirm it with lung sounds and you got them. We aren't going to go over how to secure it today just because this isn't like an intubation lecture. Look up how to do this, though. There's a bunch of great YouTube videos on how to secure ET tubes in babies. There isn't like commercial tube holders or like Thomas devices and stuff really used in these kids. It's taped. So you have to know how to tape the tube. So here is a thing real quick on end title. You need a small one. They make neonatal and pediatric end tidal caps. They're smaller, they sit closer to the tube, and they have a lot less dead space in them. So in an adult, a few mLs of dead space is fine, right? Their tidal volume is like 350 to like 550 per breath. In a neonate, it can be as low as 1 to 2 mLs per breath as a normal ventilatory rate, or as normal tidal volume for these kids. So 2 mL of a dead space, which you have in an adult end tidal, is almost their entire lung volume. So you need to use a neonatal one. So you look up and the heart rate is still 55. So you're doing CPR, you have them intubated, you have them ventilated, they're on 100% O2. Now you need to get a line because the next step's going to start being like epi and fluid boluses and stuff. So what is the fastest way to get access in this kid? So an IO would be the fastest. You could try for an IV, and if your service can, you can do like a UVC line or something like that. But an IO is quick; it's relatively easy. However, keep in mind it's not a guarantee. Have you ever placed an IO in a neonate? They go right through the back of the bone. Um, what I like to do, and this isn't necessarily manufacturer recommended, I like to take the IO needle. I ditch the drill. I take the needle off, like the little hub thing, and I will screw it in by hand. Obviously, follow your company and the machine use policy of your program. But just saying, I've had good luck with this technique. I actually take it off the drill and I screw it in by hand in the same spots I would any other IO. All right, so now let's give that epi. What's your epi dose? So the epidose in a neonate is higher proportionally than a kid. In PALS, it's 0.01 milligrams per kilogram. In neonates, it's double, so it's 0.02 milligrams per kilogram, with 0.02 milligrams being the lowest dose you give. So the normal birth rate is around 2.5 to 4.5 kilos. Premature babies can be a lot less. And unfortunately, there's not a great trick here to guess. Use an app or like a reference card or something like that. Keep in mind, Broslow tape only goes down to 3 kilograms. It's meant for kids, not neonates, so they may not fit on a Broslow tape. So you guess, initially based on the gestational age, 28 weeks is usually less. You're measuring that kid in grams, not kilograms. Between 28 and 34 weeks, you're about 1 to 2 kilos. 34 to 38 weeks, you're about 2 to 3 kilos. Greater than 38 weeks, you're usually bigger than 3 kilos at that point. This kid kind of fits right in the middle there, so should be right between 2 to 3 kilos, or 2,000 to 3,000 grams. That's 35 weeks. We're going to call him roughly 2.5, right? So we have a 2.5 kilo kid times 0.02 milligrams of epi is 0.05 milligrams of epi. So we needed to give that dose. So in your standard epi concentration, which is a 1 to 10,000 epi, that's going to be 0.5 mLs. We can also consider hypovolemia. So let's give a fluid bolus here. what is your fluid bolus going to be? So standard fluid bolus per NRP is 10 mLs per kilogram. So the fluid bolus here, we have 10 times our 2.5 kilos, which would be 25 mLs. I like to give this to using a syringe. So I'll pull it out of the bag, kind of push it slow and steady, and be careful not to pop your IO out because that can happen. A good tip for what I like to do is I like to take a 500 bag. I'll hang a 500 bag. I'll put a three-way stopcock at the end of it, and then I will close it to the patient, open it to air, attach my syringe, pull out 25 mLs, close it to the bag, push it into the baby, close it to the baby. And that way you can keep giving boluses that way without reintroducing, badness into the line. So you can push your fluid boluses in these kids. I would give it over a minute or two. So they're going to get 25 mLs over a couple minutes. Be careful with the IO. And all of a sudden you look up and the SAT's now 80 and the heart rate's 80. So maybe the kid was hypovolemic. Who knows? Maybe he just needed a quick epi-induced jump start. You don't really know. You don't really care. The team stops CPR, and before long, the heart rate's 100, 110, 120, 130, and you did it. So the kid is definitely not out of the woods, but he's doing better. You can kind of breathe that sigh of relief and start transporting mom and baby per your company's policy. And that was the fastest 5 minutes of your entire life. So you recheck an APGAR. It's now 6 out of 10, which is a lot better. Still not great, but better. And let's grab that sugar. So you take a sugar and it's 65 milligrams per deciliter. Sorry for you international folk. I have absolutely no idea what that is in millimoles per liter or whatever you guys use. Feel free to do that conversion. 65 milligrams per deciliter. Sorry about that. And that's actually okay for a neonate. So basically anything less than 40 is where you start to get concerned. So let's say it's less than 40, right? Let's say it's 38, which is usually the cutoff for treatment here. You'd need to give dextrose. So D10 is the dextrose of choice. You do not give these kids D50. Usually the dose is 2 mLs per kilo of D10, and that's usually over a couple minutes. Not an issue for this fella, fortunately. However, that's what you would do if you needed to. All right, so you call the ER as early as you can so they can have the NICU team on standby. You bypass the community ER. You take them the extra 10 minutes to go to the big hospital with the NICU. And when you make it to the ER, they point you to a room where the NICU team is waiting with a warmer. You have never been so happy to see a team of doctors and nurses in your entire life. You turn over care, clean up your mess, and return back in service. So the baby ended up doing well, and after a kind of a prolonged hospital stay for a few months, they were discharged with good neuroprognosis. So you actually got to meet him at your station. This call can be one of the single most rewarding experiences of your career. It can also be the biggest disaster you've ever been a part of. And the difference here is you, right? I highly recommend you take NRP, take neonatal resuscitation. This case was only kind of a summary of one possible scenario we could encounter, right? This isn't everything. I glanced over a lot. NRP is a couple days course. Practice this scenario, ones like it, go over this over and over and over again in your head, rehearse it, sim it with your company. Don't rely on anyone else's knowledge to get you through it. You have to seek that knowledge for yourself. So I hope this case was both helpful and eye-opening for you. Neonates do not receive PALS care. They do not receive ACLS care. They need NRP, neonatal resuscitation. So NRP is heavily based in respiratory care. It's kind of the cornerstone of neonatal treatment. And remember, neonates are aliens, right? They're not just small adults or tiny babies. They're completely different. They have different needs. They have different physiology. These babies have never taken a breath before, right? Their entire way of existence so far has been isolated hot tub where they were warm, protected, and didn't need to breathe or eat for themselves. They're literally learning how to live step by steps, and sometimes they just need some help, and that's where you come in. As always, if you have any questions, ask them in the comments. But until then, thanks for tuning in. Hope to speak with some of you, and have a safe shift.